Today, Kurt is going to be giving a presentation on marijuana and the clinical considerations that come along with that. I don't know if we have any new folks joining us today, but Kurt is Dr. Kurt Devine, addiction medicine doc, who's also done a lot of family practice. And I'm Erin. I'm a nurse that's worked in addiction for a while now.
Oh, remember there, you want you to do this. You know more about it.
Absolutely. Stratus Health is hosting a medication for opioid use disorder boot camp coming up in Waite Park, which is Partners St. Cloud, on May 7th. So that's coming up next Tuesday already. I know on the event page it says that registration closes for this on the 29th, but we have kept it open. So if there's any stragglers out there that really want to encourage their law enforcement friends to attend to learn more, this is going to be a super non-pressury session. We're bringing in some national experts to keynote, and they are law enforcement folks themselves. And it's basically just an event to get some of your hard questions answered and kind of, help shift the way of thinking with law enforcement and maybe their approach to addiction programs in their jails.
All right. And upcoming things, again, we have Elizabeth Salisbury coming next week. I saw her at the national meeting a few weeks ago. She is an amazing speaker, and I quickly tracked her down, and so she'll be next week. So do not miss that. That's going to be great. And of course, the week after, we have our friend Charlie coming back to finish up his talk, and then Alex Elswick. He's been on a few times, and he's been very popular. So we got a lot of great ones coming, so don't miss them.
And like we were just joking about as everyone was connecting, please turn on your cameras so I can creep on you and get some food ideas for some new healthy treats. All jokes aside, we love when people interact, so cameras on are always great. Don't be afraid
I have kind of low self-esteem too, and so if people don't have their cameras on, I don't know. It may hurt me, but anyway.
Free CMEs with the sessions as well. So don't be afraid to unmute and interact and keep your camera on. We love it. The more the merrier. Kurt, go ahead.
So if you have some problems, give us a ring. Erin's email and phone are there, and my phone as well. So feel free to reach out if there's things we can help you with. And again, we got a lot of different things that we can get for you. And somebody just asked, how do we get a certificate for attendance? Remember, and I think that's the next slide. Maybe you can switch slides.
Nope, I was supposed to say that on the last one, I think. I'm just, not good at my job today. Nada, it's going to be an email that Katie sends out following these sessions. And it takes 30 seconds to kind of fill that in and submit it, and then you will get your attendance verified. Katie, did I say that right?
Yep, I was just going to say you have to fill out the evaluation that comes to your email if you attend today's session. And if you don't get it, please email me.
Yeah, let us know.
And last week, the person who sends the report is out on vacation. So if you attended last week and didn't get one yet, it's because I won't get the report. So you'll get it next week.
Okay, perfect.
Thank you, Katie. Stratus Health is the home to the core website, and it's just a consolidated area with lots of policy, protocol, procedure, resources all in one place. So don't reinvent the wheel. If you have any needs, feel free to email us or check this out to see if it has something to offer you.
All right. And with that, do you have to put up the actual slide deck, or is this it, Katie? Oh, it is it. So we're going to talk a little bit today about the clinical considerations of marijuana, and just so that you understand why I kind of pulled this talk together. It's interesting to me that we have a lot of people who will certify people that they have a particular medical problem so that they can get marijuana as medical marijuana. And I think that if we are to think about marijuana as a medication, which I'll be honest, I don't. But if you look at it as a medication, you should also be having other conversations with your patient, right? About some of the other problems that we can have with marijuana. So we're going to talk about some of those things today so that people that do certify people can have the conversations with patients who believe they're going to try medical marijuana. I have no financial conflicts of interest. Obviously, I have concerns regarding the chronic use of many substances, and marijuana is just one of those. So any of the discussions regarding the pros and cons that you hear today, I frequently have in the clinic with patients. I would say 80 to 90% of the patients I care for here at the addiction clinic smoke marijuana. So it's a very common that I have. Next slide. So what we want to do, again, is educate on kind of the risks of dependence. And we want to talk a little bit about the medical issues which appear to benefit. Okay, some of the big ones that patients come in and say, I have this problem or I have that problem, and I want to try medical marijuana. We want to kind of get an idea of which things there's actually good data for. And I think we also need to talk a little bit about some of the medical conditions that there's very few papers or literature showing any evidence of effectiveness. But yet we hear about people using it for those reasons frequently. And also, I think we just need to talk a little bit about some of the adverse events that happen and some of these drug interactions that people often don't think about. We want to talk about some of the meds that you should be thinking about when patients come in and say, yeah, I got this and I need medical marijuana. Or they're just smoking marijuana and they're on some of these medications. So it's not even if you're certifying. Next slide. So just some general information now. This is really interesting because just this week this changed. Marijuana is Schedule 1. They're actually, and basically that says there's no accepted medical use, right? And the federal government's going to soften that in the next week or two, and it's probably going to shift to a Schedule 3, which, as many of you know, would kind of put it in that same grouping as things like ketamine. Do I think that's going to be? It's not going to change anything for the feds. They're still going to consider it illegal. It may benefit us in that they might be able to do a little bit more research on it. It might be easier for us to actually get data, which I think would be fabulous. And really, I don't think it fits with the other Schedule 1 drugs. It's clearly not as addicting as heroin. It's not like LSD or Quaaludes or those things. Heroin's interesting because actually in some countries that is actually used for pain. And so it does have accepted medical uses in other countries. So in that way, that's a little bit weird to have that in there. Remember, the Schedule 2 drugs are typically the cocaines, the opioids. We do have medical uses for some of those things. So next slide. So one of the things that we think about when we talk about marijuana is lifetime dependence. And really, if you've used marijuana, what's the chance that you're going to develop a dependence in your lifetime? And it's interesting because I see people in the clinic frequently who have tried heroin, who have tried cocaine, who have drank alcohol, but have never developed a use disorder. And as we know, there are some medications and some drugs that people take that they develop dependence relatively quickly. Methamphetamine being one of those that people often don't have to use many times before they develop dependence and cannot stop. Heroin is typically one of those, but I can tell you I see many patients who say, yeah, I used heroin a bunch of times, but it just wasn't my thing. And so never developed dependence. But look how low marijuana is. And in a way, cocaine, there was actually previous data where it showed that it's like 9 or 10% of people who use cocaine would end up with dependence. But really some of the latest stuff, it's a lot closer to 17. But I think the funny thing about marijuana is that the dependence develops really slowly. And we know that people that start using it earlier actually have more issues with dependence down the road. And there's actually a lot of other things connected to that we'll talk about. One of the interesting things about marijuana is when you look at the data of people who are much older, who start smoking marijuana in their 30s and 40s, they almost never develop dependence, and they tend to be intermittent users. Whereas it's this group of 13, 14, 15-year-olds who tend to develop cannabis use disorders. Next slide. Oh, a brief but interesting history. Remember, cannabis has been around for a long time. And again, all these drugs, so many of the drugs that we talk about have been around for a long time. I don't really look at drugs as good or bad. And frankly, I don't look at people using marijuana as good or bad. It's whether it's sustainable, whether it causes adverse reactions, and whether or not it's going to cause problems long term. And again, I think some of the things I look at with young people is really cognition and some of those other things. But cannabis has been around for a long time, but I don't think it was really the same 5,000 years ago as it clearly is now, with these levels of 18 and 17 and 16% THC. And in some of the vapes, we're talking 80 to 90% THC. And I've personally seen some people with psychotic breaks from those vapes, and it can be pretty impressive. It's interesting, if you look back in the 1830s, there was a doctor who was working in Calcutta, and they actually used this Indian hemp, which was clearly had some THC in it. And even back then, they were using it for pain, vomiting, convulsions, and spasticity. And he wrote in a paper about how it worked for those things. And in fact, those are the things that probably marijuana works best for. And they knew that 100 and some years ago, almost 200 years ago. So I do think that it's interesting that not a lot has changed maybe. Now, just in case they come out with a Trivial Pursuit that's kind of the marijuana box of Trivial Pursuit, I put this in there as an aside. The original draft of the Declaration of Independence was actually written on hemp paper. And so just in case that comes up in a trivia contest, that is true. Next slide. So the endocannabinoid system, I know, has been talked about a lot, and so we're not going to spend a lot of time on this. I think, Charlie's talked about it in the past, and we've had other speakers. But I think that the thing that we're just remember is those CB1 receptors are really all over the central nervous system and peripheral system. The CB2 are found in other areas, immune system, heme system, all these different places. And really the current understanding of what that does is really not there, right? And even if we look at things like testosterone levels and things like that drop with people who smoke chronic marijuana, I just think there's a lot we don't know about what these receptors do outside of the nervous system. And so just be aware that again, I think as research progresses, we're going to have a lot more knowledge 10 years from now, hopefully, that we have now. Next slide. Now, when we look at the cannabinoids, there's a few different big groups, and the endocannabinoids, especially anandamide, which is just floating around in our system, and that's why we have those different receptors. And we have the synthetic ones, which are the ones that are used fairly frequently or have some medical uses, dronabinol and anabolone. And I've never prescribed any of those. And again, these are, and these are really important, because I think those are ones that have been used for a long time. And there's actually some research on those particular ones. And then we have the phytocannabinoids, which are, of course, the things that we're seeing in the plant-based marijuana products that are floating around the market now. Next slide. So a couple of things on the phytocannabinoids. Now, delta-9 is, there's some confusion on delta-8 and delta-9. And I get this a lot because sometimes we'll get back confirmatories on marijuana, and it'll have both delta-8 and delta-9 in it. And I think the question is always going to be, which did they use? The delta-8 being what you can buy over the counter. Sometimes you'll see delta-8 in CBD. Sometimes you'll see delta-9 in CBD. But delta-9 itself, if you smoke regular marijuana, you will have some delta-8 in there, and it can be as high as 5 to 10%. And so it's not unusual to get a marijuana confirmatory back, and it will show both. The delta-8 has some THC in it, and it might be 5 or 10% as well. So just remember that the psychoactive ones, delta-8 and delta-9, those are the most psychoactive, with delta-9 clearly being much more psychoactive, but CBD being weakly psychoactive, but occasionally having THC in it, sometimes 3 to 4%. So don't be surprised if people get some kind of symptoms from that. They consider CBD non-euphoric, and I think that that's generally true if it doesn't have a lot of THC in it. But remember, there's 150 other less well-described and lower concentration cannabinoids in the average marijuana plant. And so, and plus that 500 other chemical compounds. So we are talking about something that if we considered it a medication, we don't have many medications that we prescribe that have 400 or 500 things in it. Those don't get through the FDA. And remember, this is legislatively made a medication, if you will. Next slide. So when we look at CBD, and of course, people are using it for lots of different things. But when we look at things as far as what it's approved for, really the things that it's approved for would be the seizure to some very specific seizure disorders and some very specific myoclonic seizures. Interestingly, in other countries, you can actually buy very well quality controlled products for these specific medical conditions, whereas here, not so much. But CBD does have approved conditions, and of course, CBD is being used for lots and lots of other things. Probably most notably, some people are using it for anxiety. Next slide. If we look at the synthetic cannabinoids, again, the nabilone and the dronabinol, again, these have approved indications. And so although I do not treat patients with spasticity with MS or AIDS or cancer, clearly these things have been very helpful, have been studied reasonably well in comparison even to Delta 8 and Delta 9. Next slide. So let's talk a little bit about marijuana and safety and why there's such a disconnect here. This is really a tough one when you start to dig around and try and look for literature on studies dealing with the safety of marijuana. And really that problem is that there's differing studying designs. Nobody does it the same way. All these different indications of why people use marijuana can vary from study to study. There's literally no standardized dosing. And in fact, when I was at the ASAM meeting a few weeks ago, we had a pain doctor talking about how she has a side gig where she runs a clinic where she sits people down to explain to them what might be the best way to take marijuana for their particular medical problem, whether they should be taking it orally or they should be vaping it or whether they should be smoking it, depending on what effect they're looking for. Oddly, by the way, she actually said she had no what do they call it? She didn't have any, help me out, Aaron.
I'm not reading your mind today.
Yeah, well, she had no conflicts of interest, but yet her side business is telling you how to use your marijuana for your particular problem. And in all the studies, often the administration routes can really differ. And so when they do these studies, I would say most often they're doing them with smoking, but some of them are done oral, some of them are done with vape, and so it can really be different. Next slide. Now, again, the most studied cannabinoids are the Delta 9 and again, the synthetic ones. Where we really have very little data is with the CBD, with the exception of drug interactions, and we're going to talk about that because CBD seems to be one of the worst when we talk about drug interactions, and yet it's over the counter, which sometimes can make what happens with patients and their meds a bit of a problem. Next slide. So what if we used it as a medication? How would we best dose marijuana? How do we decide how we would explain to a patient that they might take it? Well, interestingly, in this talk that I saw in Dallas, they talked a lot about, how high the bioavailability is if you smoke it and how much more predictable it is if you smoke it. And in fact, patients would typically can just take a hit, if you will, every so often to maintain a particular level of their THC so that they get the desired effect that they would want, right? And to sometimes maximize the psychotropic effects or minimize the effects that they want. And I've had patients say this to me, that they, for instance, they have anxiety, and what they find is if every 3 or 4 hours they take a puff of marijuana, it calms it down. And we'll talk about whether or not that's really, whether that's really a great way to do this. The problem with the oral forms, and I've had patients tell me this all the time, is that they're very unpredictable. People will take an oral one, and I've had patients who, went to Las Vegas, for instance, and it's legal there. They go down to some shop, they buy 4 or 5 gummies, they take 1 or 2, they feel nothing. And so they take 2 more, and then of course the delayed response puts them in a bed for about 6 or 8 hours, not knowing what's going on. And so really it's a very difficult one because of the first pass hepatic metabolism, and the levels of active agents vary. The absorption can be very different whether you ate or not, and between people. And so I've heard some pretty interesting stories about how when patients take this orally, how that can really be quite interesting. Now, vaporizing it may not be the worst way. And in fact, when people vaporize it, it actually avoid the smoke and some of those toxins that we would get from cigarettes and all the other things that are in marijuana. And so there are people that either vaping it or using a nebulizer might be a better thing to avoid some of the worst pulmonary issues. Next slide. So we're going to move on to mental health. And mental health is a big issue when we talk about marijuana. There are actually some fairly recent studies that I think are pretty helpful. One of the guys, Dr. Hassan in 2021 and his group, actually looked at the National Epidemiologic Survey on Alcohol and Related Conditions, and also the NSARC, and looked at all the National Survey on Drug Use and Health. And they really scoured this to kind of look at the comorbidity of cannabis use and really cannabis use disorder with other substances and psychiatric disorders, trying to kind of show either correlation or causality, whether or not that would be helpful. Next slide. One of the things that we have to think about, next slide, there we go. One of the things we have to think about is really these 2 words, because it's one thing to show causal or a relation to marijuana. It's a whole nother thing to have association. So the things just happen to occur or have co-occurrence, whereas, showing marijuana is the cause of a problem is sometimes much more difficult. And so just keep these 2 things in mind as we kind of look at some of these studies. Next slide. So the results of Hassan were kind of interesting. And basically what they could tell is there's definitely strong evidence that people have had past year diagnosis of a cannabis use or cannabis use disorder is very obviously associated with psychiatric comorbidities. Now, the complexities are not understood, right? But we know, and we've talked about this a lot on the Echo in the past, that you have a much higher rate of psychosis, that you have more mood disorders, more anxiety, and in fact, marijuana use, whether you have a use disorder or not, is strongly associated with personality disorders, and we'll talk about that. Next slide. So when we look at the use disorder and psychotic disorders, they did a review and meta-analysis, and actually they could see very clearly that there's a causal factor in both incidence and prognosis of psychosis. So this is one of the areas that's a little bit more clear-cut in comparison to some of the things which just show that there is that just show more that they co-occur than causality. It's very clear that THC is that common component that increases the risk. And actually, there were some comments in the study about a 6-country study that confirmed that increased frequency of use and potency, and that being associated with the timing of the first episode of psychosis. So in short, the stronger the weed, the more often you use it, the timing of your first episode, which would mean earlier episodes of psychosis, were more common. And so I don't think that this really can be argued. This has been very clear for a long time that this causes some issues. And we'll talk a little bit about long-term and how that affects some of these things as well. Next slide. It even showed that the previous use of cannabis, so even if you have a patient who smoked marijuana for 10 years and has not smoked for 5 years, they still have an increased risk of first episode of psychosis. So stopping, there's no clear defined time period where if you stop that you're not at risk for the psychosis. I think that's interesting because if you look at cigarette smoking and lung cancer, for instance, we know that if you've stopped smoking for 10 years in your midlife, that really by the end of that 10 years, your risk of cancer goes pretty much back to what a normal person's would be. But when we look at psychosis, we know that stopping may not completely spare you. And really, it's that continued use that predicts the severity of your symptoms and really worse overall functioning. I have one patient that I've seen recently, and he had methamphetamine-induced psychosis, but continues to smoke marijuana. And he has really significant psychotic problems and issues and is on medications, but is still not completely controlled. And as much as we talk about the marijuana, he really feels like that is benefiting him and not hurting him. But in fact, it's probably overall his function long-term is going to be worse. Next slide. This is an interesting study that was done out of Sweden, and I think it's interesting mostly because how long it is. They actually followed 50,000 people in this study for 27 years, and these were actually people that were in the military. And so they had very good data on these people that they kept for a long time. And when they looked at this group over this 27 years, the things that became very clear were that, number one, that if you started using it as an adolescent, the use in your adolescence increased your risk of psychosis without a doubt. Now, interestingly, when you looked at the people who even used it more than 50 times in those 27 years, they had a 7 times increase in diagnosis compared to those people who'd never smoked. So again, I think this is probably one of the longest studies with the largest amount of people. And again, very clearly shows an association. Does it cause psychosis? There's an Australian study that they talked about during this that said no, but it was a much smaller study. So again, I do hope that with time, we get more studies that show us a little bit more about causality. Next slide. So let's talk a little bit about the mood disorders. And it's interesting how mood disorders and cannabis use go back and forth between each other. And if we look at people who've already been diagnosed with a major depression, they actually look at cannabis when they're surveyed as really not being risky compared to people who do not have major depression. So their perception right off is this is relatively safe. And if you look at those people who've had past year or even lifetime history of a use disorder to cannabis, there's a much higher prevalence of mood disorders. So it goes the other way as well. And in fact, you're twice as likely if you have had a cannabis use disorder to have a major depressive disorder, and twice more than 2 times higher bipolar 1. So again, lifetime use, it's certainly not causal that they can tell, but there is certainly obviously co-occurrence. Again, the national study data from 10 years, from 2002 to 2012, showed that even just daily and non-daily use showed that there was 2 times prevalence of psychosis. There was 2 times as prevalent in those with major depressive disorder than those without. And so it doubled your risk. So I do think that really when we look at the mood disorders, it kind of goes both directions. And all the studies are kind of showing that. Again, not causality, but clearly co-occurrence. Next slide. Anxiety is the one that I hear the most, and I suspect all of you hear this as well. I would say probably more than half of the patients that I see tell me that they're taking marijuana because it helps their anxiety. And I struggle with this one because there are many studies that show worsening anxiety, which is associated with higher dosing of marijuana. And again, we got to compare that a little bit to CBD because we know that there have been some smaller studies that have shown improvement in anxiety for CBD, but there have not really been those studies when we look at marijuana itself, THC, and anxiety. Often when I talk to patients, they'll be smoking marijuana every hour or two. And then a week, an hour later, they have to retake it because they're either feeling a little bit of withdrawal a couple hours down the road, or the anxiety comes back, right? It's really just maybe covering it up for a very short period of time or worsening it. When you look at patients who use cannabis weekly, that's been associated with nearly double the risk of patients later reporting anxiety or depression. So I think we have to look at daily use as clearly a problem. Daily use carries nearly 5 times the risk of being diagnosed with anxiety or depression down the road. And I have that conversation with patients every single day. There's, again, no determination that cannabis is solely responsible, but I think the data is relatively clear. Next slide. One of the things that we hear also, and we have patients talk about, is their PTSD. And Charlie, 2-3 weeks ago, alluded to using marijuana for PTSD. It's funny because I've seen some of that stuff before, but I had also read a lot of things about REM sleep and marijuana. And as Charlie pointed out, when you're in your REM sleep, that's when you have any dream. And if you're using marijuana to try and somewhat dampen these bad dreams or this PTSD, often you're not getting good REM sleep, and it's really much akin to having sleep apnea. Now, the NESARC data showed that there was a 4 times increased risk for the patients who have PTSD of actually developing a use disorder to marijuana. So I think there's also that issue, is that can people maintain their marijuana use to a level that they're not going to develop other problems. And we'll talk in a minute too about other substance use with cannabis use disorder, because although developing the cannabis use disorder might not seem like a terrible thing, sadly it leads to other things, and we'll talk about those. So both of the big national studies really showed a comorbid relationship between cannabis use disorder and anxiety, all types: agoraphobia, PTSD, GAD, and panic. So again, when I get it's the only thing that helps my anxiety, this is the discussion that I have. Next slide. Bottom line for me with anxiety is that the role of cannabis in the etiology, prognosis, and treatment is unclear. I think that most of the data really leans toward it worsens it. And are there maybe some people that it helps? I think that's certainly possible. But I think as a large group, we have to think that most of our patients are probably not benefiting, and maybe it's making them worse. And especially when we think about their sleep and some of the other issues surrounding PTSD and bad dreams. Next slide. Now, personality disorders is kind of interesting because, of course, with personality disorders, we see a lot of substance use. And when we look at cannabis use disorders, it actually has an association with all 10 personality disorders. Every single one of them seems to have a relationship with that. If you look at the ones that are most often related to cannabis use, it's antisocial and dependent personality disorders. But really, any cannabis use is associated with higher rates of other substance use disorders. And so, again, when we talk about people with PTSD being high risk for a cannabis use disorder, often that leads to other substance use disorder as well. If we look at the patients who have personality disorders, they're actually 4 times more likely. One second, I'm going to shrink that. More likely to have a past year cannabis use disorder than controls. So again, personality disorders and all substance use is an issue, and often cannabis, is kind of the tip of the iceberg, and we always have to kind of think about that. Next slide. And this leads us to the gateway theory, which is the super controversial thing. I actually gave this talk at a different conference a month ago, and when people see gateway drug theory pop up, everybody kind of like, yeah, we've been talking about this for a long time. And I don't know that with gateway, you can talk about causality. I think it's more that we know that people who regularly use or heavily use marijuana clearly have an association with increased risk for both misuse and dependence of other substances. That data is very clear. But again, causality, no. Directionality, one causing the other, no. But there, again, one very long-term longitudinal study showed a very strong association, especially when we talk about adolescent use and later drug use. And it also showed cannabis use increased the frequency. So the more cannabis they use, the higher frequency of illicit drug use in the end. And so it's the heaviest adolescent smokers as they move through life that seem to have the most trouble. So again, gateway theory, causality, not there. Association, it's clearly there. Next slide. This is the one that I find really interesting because when we talk about marijuana, we often don't think about what's the most common problem that a patient's also going to have. When I see patients who have a significant issue with cocaine, the first thing I think of is alcohol, because so many of the cocaine patients use alcohol, as you all know, because they actually work together and they form cocaethylene, which kind of extends the high that they get from cocaine. Now, interestingly, when we look at cannabis, if you have a patient that drinks alcohol and uses any other drug, marijuana would be number one. So if you have somebody who drinks a significant amount of alcohol, marijuana is likely. Now, if your patient actually develops a cannabis use disorder, or you're seeing them in a treatment, they've just gone through treatment for that, they have a 50-50 chance of also having an alcohol use disorder. And so when we think about marijuana as a use disorder, it's a 50-50, a flip of the coin, that we need to be having a conversation about their alcohol use as well. And I think in all our clinics, when we're seeing even patients with, they're using buprenorphine for opioid use disorder or other things, the alcohol conversation always has to be brought up, because I would say probably a third of my patients on buprenorphine will occasionally drink alcohol, and they also smoke marijuana frequently. But when you look at the studies, and some of the stuff is even has come out of Colorado, we know that if people use cannabis and alcohol, they tend to drink more. They seem to have more likelihood of getting a DUI, and they're also at higher risk of self-harm or suicide. And actually, if you look at some of the Colorado data, we know that alcohol sales went up about 20% roughly when they legalized marijuana. And although they thought DUIs would go down, they actually went up. And if we think about it, if you're drinking alcohol and also smoking marijuana, it's that perceptive issue that we get with marijuana that often makes driving a little bit more difficult. Next slide. So how about the other substance use disorders? Well, there's been a lot of studies that have shown that if you have patients who just straight out just smoke marijuana intermittently, no big deal, their non-medical use of opioids, especially if they have pain, is much higher. And in fact, it's even higher in the general population. So if we have people smoking marijuana, they have a much higher use of opioids non-medically than the general population. And if you look at the VA system, they did a really interesting study where they looked at patients who developed a cannabis use disorder. And what they found is that it was actually associated with a higher number of opioid prescriptions. Those patients got more opioids than anybody else. And so there is certainly a connection. Again, there is a kind of a co-occurring thing going on. And we just know that one of the things that often people think that the cannabis is helping their pain, but it just seems like often they still use more pain pills than people who do not use cannabis. Next slide. And it's funny because I think too, if you look at cannabis use disorder, and if somebody has that diagnosis, is going to treatment for that, they have a higher prevalence of other substance use disorders across all drug classes. And I think that even if you look at the club drugs, it's at 16 times higher. But I think that really it's like, even if you look at opioids, they have a 5 times higher chance of having a substance use disorder to opioids than the general population. So I do think that that's something that we have to think about. We never just stop at, oh, you smoke marijuana. It's in my clinic, you get a whole handout, and we want you to tell us all the other different drugs that you've used or are currently using. And I do think that should include kratom and teneptine and all those things that we see in the community. Okay, next slide. Cannabis and nicotine, the only reason I put this up there is because when we see adolescents and they're smoking, I think it's important for us to understand that they're more likely to be smoking marijuana and cigarettes together than they are cigarettes alone. Twice as likely. So when I see young people and they're smoking cigarettes, my next question is, how much weed do you smoke? I never say, do you smoke it? I say, how much? And it's very frequent that they're doing both. It's just not common to do one or the other. Matter of fact, to me, it's like I just don't see people smoking marijuana that don't smoke. Most of them smoke cigarettes also. So just keep in mind that that's something we always need to kind of explore. If somebody says, yeah, I smoke cigarettes, remember that cannabis is going to be a potential there as well. Next slide. Cancer is also on the docket. There have been a lot of studies with lung cancer, relating to marijuana. I've seen these over the years. There's not really great ones, and part of the problem is trying to relate it to how much they're smoking, where the marijuana comes from, what's in the marijuana. Are they also smoking cigarettes? All these things can really confound what your results are. Tunisia actually did a fairly big study, and then they decided that there was some concern that tobacco had been mixed with their cannabis, but they had an 8 times higher risk of lung cancer in patients who were smoking marijuana, possibly with cigarettes as well. There's been some better studies that were pretty much controlled for tobacco use that showed that it probably doubles your risk of lung cancer from whatever your level was prior to that. So understand that even just smoking 50 times in your life, that risk often does not go away. So smoking does add to it, but there is certainly a problem with cannabis associated with it. Next slide. Some of the other studies have shown different types of cancers, and I found this pretty interesting that there's some increased risks of prostate and cervical cancer in cannabis smokers. Again, there's a correlation. We don't know that that's a causal, but there also appears to be a risk of adult gliomas, regardless of tobacco use. So I thought that was interesting. And I think that when we talk about pregnancy and women smoking during their pregnancy, that's actually associated with increased childhood leukemia, astrocytomas, and rhabdomyosarcomas. There's no dose data on that, like how much a pregnant woman has to smoke to get into those in that data range. But there's certainly been associations between that. So it's always something to counsel patients on. There's a lot of other great reasons not to give marijuana to pregnant people, but this would be one of those. Next slide. Sleep is probably the second most common reason patients say they're using marijuana. I use it before I go to sleep. And it's a common reason to use. There are very few studies. If you look in the literature, there are a few studies where they watched, they did somnograms, they did all kinds of stuff. What we do know is that there's probably some disruption in the REM sleep. Again, we talked about that earlier. The problem with these studies is they're very subjective. And, like, how'd you sleep? Well, I slept better. How fast did you get to sleep? Well, I think it was quicker. And so it's very subjective, and it's hard to do this. There was probably the biggest study even had a pretty good flaw, and that's that they were basically comparing sleep study on nights that people smoked and nights people did not smoke, but they would go every other night. And so patients, of course, would be probably feeling a little withdrawal from not having smoked the night, the non-smoking night, and how did that affect their sleep? And so it's really not clear. I think, again, there's a pretty good data that it probably affects REM sleep. It decreases the bad dreams, but what's the long term if you don't get REM sleep? Next slide. Cognition is probably the most important thing I talk to young people about. And I honestly don't pull many punches on the cognition when I got a 17-year-old in my office. I really explain to them that this is going to cost them some IQ points. And there's very good studies that show decreased white matter in areas of the brain related to memory and verbal learning. When you look at users and non-users, there was a study not too long ago that showed very similar findings in patients with cannabis use disorder who are adolescents compared to controls, and showed very significant changes in IQ scores and slower cognitive functions. I often bring this up when people are 16 or 17. And I had one kid say to me, so what you're trying to tell me is I'll be dumber if I keep smoking marijuana? And I said, well, I'm not going to use that word, but your IQ is going to certainly be lower as time goes on. Next slide. I think one of the things with it is we don't know how frequency of use and age of onset affects these cognitive outcomes. We know that executive controls and recall times are different in people using marijuana. And often I have this discussion in patients who also think they have ADHD, because do we put somebody on a stimulant or do we leave them on a stimulant when they're 16, 17, 18, and they're smoking marijuana, which affects their cognition? How do we deal with that particular problem? And that's really a patient by patient issue. There've been a lot of studies on cannabis and academic performance. And again, there's so many different things to think about in those types of study, but I think most people would say that it leads to poor academic performance. And I think that's the thing that we have to kind of relay to our patients. I just had a kid who stopped smoking marijuana in college. And he came back after a month and said he really felt like he was having much better luck studying than he had previously. That previously he would get sidetracked, he would fall asleep. He just didn't feel like he remembered things, and he felt like that was really improving. And of course, that's a study of one. But I do think it was interesting how dramatic he felt it was after a month, and he was a relatively heavy smoker. Next slide. Again, the long-term chronic cannabis, there's not much to be found in the literature. Again, we know that the adolescent cannabis use and neurologic functioning data is limited. And again, I think most researchers would tell you that down the road, they're going to have this information that shows that these structural changes occur over time, and it's not going to get better. It's clearly going to get worse. But again, no data. Next slide. One last area, prenatal exposure. This is an area that is very hot topic lately. And I think that one of the things we have to understand is smoking itself causes problems. Now, if we're smoking marijuana, probably the thing that affects most is fetal growth. And so we know that we have if patients smoke throughout their pregnancy, that we're going to probably have a low birth weight baby. Why this happens is really not completely known. But it appears to be associated with some other kind of negative metabolic outcomes. There's also pretty good evidence that there's an association with deficits in memory, attention, and learning as those children grow. And in fact, there's some data regarding patients with psychosis in their early years, patients with autism, and numerous other things in moms who have smoked rather heavily during their pregnancy. Next slide. And so we do think that even in those children that it probably increases depressive symptoms. And again, these prodrome symptoms of psychosis and sleep disturbances, lots of different things that I think we really need to worry about in children of people smoking marijuana during their pregnancy. And so we should really be trying to limit that as much as possible. Next slide. Drug interactions we're going to talk about for just a moment, and it's really more probably geared towards CBD, but I do think with THC there are still some issues with the CYP and P450 pathways. These things have not been well worked out, and again, a lot of this stuff is based on theoretical interactions. There have been some clinical studies on THC and fewer on CBD, but again, because of how CBD works, there's much more concern regarding CBD. Next slide. And some of the things that just to think about is that they do affect levels of antidepressants, antipsychotics, opioids, benzos, even warfarin, and PPIs. So you need to kind of keep those in mind. The seizure drugs also can be a problem. Buprenorphine we don't worry about too much because, of course, there's a ceiling effect of that anyway if it increases the dose of that. But again, I think especially with warfarin and some of the seizure medications, I think that's important to remember. Next slide. So the bottom line, if symptoms are occurring that you might think would be a drug-drug interaction, please look it up. There's lots of different things that can happen, and remind patients, especially if they're taking over-the-counter CBD, that that's something they should explore. Next slide. My final thoughts. Cannabis has about 500 compounds, and most of these haven't been studied. So, it's the bit of the Wild West. If you care for people who use cannabis, whether you're certifying or not, I think it's important to make sure that you discuss some of the issues surrounding its use and look at their medicines that they're on and the problems that they're having to see if they might be related. I think that most patients and many providers consider it safe, but again, the adverse reactions occur. And with medications, it's very important to kind of educate our patients. If we're going to treat it like a medication, I do think we need to have more conversation than just certifying. We need to look at even patients using it recreationally and whether it could be dangerous. So, all right. Thank you very much. A lot of sources. Knock yourself out reading all of those. Happy to take any questions that people have. And if I can't answer them, we may have somebody on here that could. You never know.
Kurt, I have one in the chat that is not related to this talk, but super duper important. And I did not have a great answer to this when this person emailed me. So I'm going to start with that one, if that's okay. And
sure.
does
we'll see if I can answer
it. Does anyone utilize or know any online resources for meetings that your patients who cannot or do not want to go in person? Any groups that you all would suggest or have heard positive feedback on that are like teleplatforming?
I think there's quite a few that some of the people I see on here can probably chat in. But I don't know specifically. I have patients that do it. I don't know where they go for these meetings.
Feedback I've gotten is like NA, sometimes folks feel like they don't necessarily fit into that being on mood. But that's okay, perfect. Okay.
All right, other questions? Feel free to unmute if you'd like as well.
Couple, but starting off, this is Sean. When I worked with kids with autism, there were several that had cannabis to curb the aggression,
yep.
Which is interesting because you're giving cannabis also to a minor. So I don't know what thoughts you have on that. It's not more of a question, more of a statement.
Yeah, and I think that came up when Charlie was talking too about using it, and I know that that's one of the uses where it's been used to kind of help calm that group. I think for the most part, I don't disagree with that kind of use. I really think that if we find a niche where it really seems to help people be more functional and improve things, I think that's great. So, yeah.
And my second question is with THC and all that being legal in Minnesota now, I've noticed a few different towns, my town including, now having THC infused drinks and bars. What do you think about the interaction of alcohol and THC, or the oral dosing of THC through the drinks?
And again, I went to liberal arts school. It's everything in moderation. I think that anytime you mix THC and alcohol, you're going to get more DUIs. Again, it's the perception issue that you develop with THC that they believe, like in Colorado has caused that increase in DUIs. It's because people are, they might have one drink and be fine to drive, but then when you add the marijuana on and you get perceptive issues, it may make it way different. So yeah, I'm not in favor of that. I think anytime you mix any two substances, it causes interesting issues, right? Yeah, I wish they wouldn't do that, but it's a market. Other thoughts, other questions?
You talked about, marijuana being a gateway drug, and something I've heard from patients so often is like, do I look at it as a gateway drug? I don't know if I really do from a clinical perspective. That's what they say. But considering a lot of the dealers that they've been in contact with who deal marijuana also deal something much stronger and more addictive, and it's a business for them, and that's how they get people started in an active cycle of addiction to perhaps something much more harmful than marijuana. So that kind of made my light bulb go on with the gateway drug connection.
Yeah. And I've had a lot of patients who said they were just buying marijuana and then somebody gave them a free sample, right?
Yep.
And in fact, I tell you, I had a patient who was in withdrawal and went to the head shop in town, and they gave him a free sample of kratom, which helped the withdrawal, but then he started using kratom and ended up here. So I do think that, and I ask patients that all the time. I said, well, does the person you buy the marijuana from sell anything else? And they were like, well, sure, and I always say, well, that's the danger, right? That's the danger.
That's what scares me with young people the most.
Yep. Yeah. Anything else? So again, I'm not a huge fan of marijuana. Again, I don't look at drugs as good or bad. I just think that everything in moderation. I think that we just need to really think about, some of the things that can happen with marijuana use, and understand that it's not particularly safe long term. I think especially when you start young. If you look at people that start smoking marijuana in their 30s and smoke intermittently, I don't think that's a group that we're going to ever have a big issue with, right? It's the people who start when they're 15 and 14 and 13 and 12, and they affect their brain function that young, and don't make the connections they should. Those are where we're really going to see some trouble down the road. So, that's my biggest thought. All right. Well, we're out of questions, Aaron. I must have answered them all.
Katie, can you comment to Nada on the PowerPoint being available?
Yep.
I think
I put it in the chat, but yeah, it'll be attached to the session email that goes out after this, along with the eval link to get your certificate.
All right, everybody, remember next week we have our friend from Wisconsin talking about harm reduction, and again, a wonderful speaker. So make sure you make that one. You'll find her very interesting and super sharp. So thanks everybody for coming, and let us know if there's anything we can help you with.